Hey guys, Kim here, and you are tuned in to Kim E, the Diabetes MP, a place where healthcare professionals can come learn more about diabetes care to increase their patient outcomes. Now, we have been sitting here for the month of May and talking about the older adult with diabetes. May is Older Americans Month, and so in an effort to speak about all older adults, just not Americans, I felt like it would be very appropriate for me to sit down and pull out some very hot topics with this population. And so we've gone through and spoken about other hot topics. I will link those videos down in the description box so you can watch them. But today we're going to talk about hypoglycemia. Now, I have put out a number of hypoglycemia videos just for the person who has diabetes in general, but hypoglycemia is something that you do need to pay attention to with the older adult. They are at higher risk for multiple reasons, but this is something that you do need to pay attention to. So let's get on into it. So hypoglycemia. Now, I have defined hypoglycemia in previous videos. Again, they're linked down in the description box. But there are stages to hypoglycemia, right? It's not just my sugar has dropped. You know, there's an actual defined what is hypoglycemia. So I'm going to make sure that I get this right. Stage 1 is anything that's less than 70. Stage 2 is anything that's less than, I believe, 54. And stage 3 is any time that a person, no matter what the reading is, so it could be 72. But anytime a person has neurocognitive impairment where someone else has to treat their hypoglycemia, that is considered stage 3, right? And so when it comes to hypoglycemia, we always need to address it. Okay, no matter what happens, if a person tells you that their blood sugar is dropping, you need to address it. That's not something that you just be like, well, okay, well, make sure you eat something. No, you need to investigate. Okay, because we never want any patient to have hypoglycemic episodes, and we especially don't want that in the older adult. So here are some special considerations for the older adult, and some of these things they're common sense. Okay, and some of it is like when I say it, you'll probably be like, yeah, that makes sense. You know what I'm saying? So let me just kind of read them off. So for one, older adults are at higher risk than the younger adult to have an episode of hypoglycemia. Okay, so just know that. Now, it can be for a myriad of reasons. And some of those reasons are because there may be an increased cognitive impairment. Maybe the patient has a little bit of dementia and has forgotten to eat, and they're on a medicine that induces hypoglycemia, like an insulin or a sulfonylurea, something like that. Maybe there's some type of functional impairment. Maybe they're not able to see very well, so it's harder for them to pull up the correct amount of insulin. Maybe their dexterity is not as good, and it's hard for them to do that smaller needle. Okay, so in those situations, there are amplifiers, magnifiers, there are different needles for the person who has that issue. And so these are the things that you would want to explore with your patient. You know, a return demonstration will tell you a lot about stuff. So you always want to be evaluating this, okay? Something else to consider, there may be some food insecurity or inadequate food store, and this will affect the nutritional status. If a person's not eating enough, but they're taking insulin, that's a problem, okay? If they're rationing out food, that's a problem, you know? And so that's when you will get some social work in there to help, get some help in there to help them. But then also, if you know that the patient is not eating as much, then clearly that dose of whatever they're on may need to be decreased, right? Possibly. So I've already touched a little bit on visual impairment and dexterity, but just something just to keep in mind is that you may be dealing with a patient that has glaucoma, that may be already dealing with some blindness. Also, not just with their medications, but even when it comes to visual impairment, I find that those glucometers that actually have, that speak, that actually have like a person that actually, you know, the little operator on the thing actually tells them what their reading is and tells them what to do, and that they have a display that is big enough with big numbers. Those things are very, very beneficial to them. And if you find that you have a person that is dealing with some visual impairment, limited vision, you need to go ahead and switch them over to stuff like that. Also with dexterity, keep in mind that you may have somebody who is dealing with some neuropathy, even maybe some carpal tunnel, and that they may have some numbness, maybe not able to grip like they need to. You know, in the person who doesn't have diabetes, that could be an issue, but all the more with the person who has diabetes, you do need to be assessing that. And then again, you know, changing whatever tools or whatever supplies that they have to accommodate them. And then lastly, definitely where you're going to see your high risk for hypoglycemia is the person that's on insulin or the secretagogues. And so for those who don't know, and I have made lots of videos over medications, so you can go and refer to them. I specifically talked about the secretagogue sulfonylureas as well as meglitinides. You will probably not see a person on a meglitinide. For one, it's expensive. It's expensive, and it does pretty much the same thing that the sulfonylurea is. It's just more of a shorter term secretagogue. So most people are not going to prescribe meglitinides because you have sulfonylureas, and they're very affordable. Most people get them for free. Their insurance covers them 100%, and if they don't, they're all like, there's like 2 or 3 of them that are on the $4 list at all times, if not all of them. And so so you probably will not see someone on a meglitinide, but you will see people on sulfonylureas. If a person is on insulin or sulfonylureas, there is a lot of education that needs to happen, okay? Because we do not only are they're an older adult, which puts them at higher risk, they're also on a medication that will induce hypoglycemia in anyone, okay? So that's something that we do need to be talking about at every visit and addressing at every time. You know, we do not want that, okay? And I've mentioned this in a previous video. Hypoglycemia increases a person's risk for dementia. We don't need to be inducing dementia in our patients, so it is one of those things that you do have to address when that person has an episode, okay? Of course, some other things that hypoglycemia puts people at risk for is falls and injuries. You know, people pass out from hypoglycemia. And not only do you need to address the signs and the symptoms of hypoglycemia, you also need to educate the patient and their family over what to do, how to treat hypoglycemia appropriately. What do they need to eat? What, you know, and anyone that has who's on a medication that can cause hypoglycemia, they definitely need to have an emergency kit. They definitely need to have a glucagon emergency kit for that, and they need to be properly changed over that. And again, I'll link my other videos to hypoglycemia so you can learn more about it, as well as link some other resources for you to read on your own. Okay guys, that's all I have for you. I hope you all have enjoyed this month's theme of the older adult and diabetes. I thought it was very good for me to address this. For one, I really love taking care of this population, and I know so many of us take care of this population, and so I wanted to make sure that I address this and just give some just good clinical pearls and best practices over what you can do to implement some of these things in your own practice. If you have not already, could you go ahead and like this video? Subscribe to this channel if you have not already. Ding that notification bell so you do not miss an upload. Again, you have been sitting here with Kim E, the Diabetes MP, and I'll catch you on the next video. Bye.